All right, good morning again. This is Senate Health and Welfare, and we are now moving to look at S-263, which is a bill relating to graduates of international medical schools. And we're a little bit late on our agenda, which is not unusual. I see Chris Dougherty is smiling. Do you know?
You're doing fantastic, actually, I think.
So, Chris, are you on a time schedule? Would you like to testify first?
I would be comfortable with testifying first, or I can certainly yield, and I probably have until 11:30 today.
Oh, okay. So why don't we do this? Why don't we stick with our agenda then, and we'll go to David Herlihy.
Thank you.
David here.
Yes, I am.
Oh, terrific. I don't see you yet. Can we get this on there?
Oh, sorry. My video is off there.
Ah, there you are. Oh, good to see you again. So, two of our committee members will be coming in. We've been on a little bit of a break, so, but your testimony is very welcome on S-263. So David, why don't you introduce yourself for the record, and then we'll hear what your thoughts are.
Sure. Good morning. Thank you, Senator Lyons. I'm David Herlihy. I'm the Executive Director of the Board of Medical Practice and the Director of Hospital Licensing for the state of Vermont. And I was asked here today to speak about S-263. And I have to start by saying my board hasn't had a chance to discuss this yet and state an official opinion on it. We can talk about it at our meeting next week. Will be the first opportunity. I can say this, that I'm on a national committee. I'm on the state advisory committee to the United States medical licensing exam, which is the exam used by all U.S. jurisdictions to license physicians. That's given both to U.S. grads and international medical grads who seek to become licensed in the United States. And I was at a meeting in November in Texas of that committee. We meet quarterly, and I don't think I've ever seen a single issue as the Tennessee program cause so much concern among representatives from medical boards across the United States. I just like to give a little bit of background. Right now, roughly 25% of all the physicians in the United States practicing are international medical grads. And international medical grads, that there are two distinct components to that. There are United States citizens who were, for the most part, born here, raised here, went to college here, who go to international medical schools, many of them in the Caribbean or in Mexico, some other locations, as alternatives to getting into U.S. medical schools. And I'm not sure exactly of the breakdown. I know I've seen the figure. I'm sorry I don't have it this morning, but I think that maybe, I think they're about 15 or 20%. That may be off. It may be a little bit higher of all the international medical grads. The balance of all the international medical grads are individuals who grew up in foreign nations, went to medical school there, and then followed an established pathway to come and practice in the United States. And as I said, right now, about 25% of all the physicians practicing in the United States are international medical grads. And it's closer to 30% if you look at the percentage of all the new licensees in the United States each year who are becoming licensed for the first time to practice in the United States. About 30%, 28 or 30% are international medical grads. So there's already a very robust system for having individuals who went to schools in countries other than the United States and Canada to become licensed here. The history after World War II, there were we were beginning to see foreign educated physicians wanting to come to the United States, and in the 50s, an organization called the ECFMG, the Educational Commission for Foreign Medical Graduates, was established. It's a huge organization. It's headquartered in the United States, has representatives all over the world, and there are subdivisions of it. And the whole purpose of ECFMG is to ensure the legitimacy and validity and adequacy of an individual's credentials when they're coming to the United States from a foreign medical school background. And there's this huge framework that we rely on that ensures that the schools are adequate and provide appropriate training, and that the documentation presented by the individuals is valid and represents what it is submitted for. And it's very, when we talk about creating new pathways, it's very daunting to people from medical boards who have the mission to protect the population and ensure that the practitioners who we're licensing have the qualifications that they present to us and that they're legitimate. It's very, very daunting to consider the prospect of some new pathway that does not have an established framework for ensuring that what is presented is true and accurate. And so when I saw this bill, I was really somewhat concerned. And as I said, I saw a number. There's several people on this committee I'm on that advises the USMLE, and physicians, public members, everybody was extremely concerned. People who understand the work that medical boards do, vetting the credentials of individuals to practice in the United States. And again, I started off with talking about how the fact that we have, about 30% of all the people being licensed to practice in the United States every year now are international medical grads. And I think that really at a minimum raises a question of, well, why is there a need for a different pathway than what's established?
So, David, so I think we hear what you're saying, and we understand that the board will be meeting next week, and it would be helpful for us to hear the board's comments about the bill. It is a working group, as you said, because I do want to give the CEO Dougherty an opportunity to his 10 minutes before 11 o'clock. So
Okay.
Do you have testimony that you can submit electronically?
I've not yet prepared any written testimony, but I would have a chance to do that probably over the weekend.
Okay, that would be helpful, and then as the board considers the bill to have further comments, just on the board's comments, and together with yours, that would be helpful.
Okay, all right. Thank you for the chance to speak.
Yeah, no, thank you, I appreciate it, and I appreciate all the work you're doing, and particularly at the national level, that's impressive. So we have Chris Dougherty here from Brattleboro Memorial Hospital. Thank you for being here with us.
Thank you. It's an honor to be here, and I'm really delighted to be here with you. I am Chris Dougherty. I am the President and Chief Executive Officer of Brattleboro Memorial Hospital. And I think Mr. Hurley's testimony is very compelling. And I want to try and talk about two sides of the same coin. Quality is of vital importance to everybody in terms of healthcare, hospitals, health systems, federally qualified health centers, the community, most importantly of all. But so is access. And Vermont is in, I think, a very challenging way in terms of access to care. I think on average, the availability of primary care appointments, new patient primary care appointments, is about 200 days at this point in time. That is not where anybody should be. We're embarrassed to say that's where we are at this point in time. We'd like that to be within 2 weeks time frame that you could see a primary care physician. What that means is when there's no access, quality suffers a great deal. Patients end up seeking care in emergency rooms where they get episodic care instead of continuous care. What I like about Act 263 is it is to set up a study group. It's not to actually say that let's start granting licenses to international medical student graduates. It's to set up a study group. My hopes to see how it can be done effectively with the highest quality of care. Many of the things that Mr. Hurley mentioned absolutely needs to be considered. I think that at this point in time, Vermont, Brattleboro specifically, is so challenged for access. It is a very hard recruit to bring doctors, nurse practitioners, physician assistants to this community, that I think we need to be very innovative and maybe seek new, more modern pathways of getting into the system so that we can take on this challenge of access head on and actually succeed through it. Again, I see access and quality as two sides of the same coin. I do not believe they're in competition with each other. My goal would be to see something studied that would look to see how can we innovatively enhance the access to care for Vermonters, but do it with the highest quality that the state has come to know, and one of the best quality states when it comes to healthcare in the United States. I think as we look at the reality of an aging population, Vermont being the second oldest state in the United States, the access issues are going to become even more severe in the future. The elderly population have multiple chronic illnesses, which takes much more time for primary care clinicians. And it's going to make it even more difficult to offer access in a timely fashion to all that need that access. So I do see that as a challenge for the future. You'll also be hearing, I know from Oliver Wyman about their study of hospital sustainability and transformation in Act 167, and the state is looking to go to global budgeting for hospitals. And come January 1, 2026, and they're really, the way to succeed in global budgeting is to have a very great availability of clinicians, high quality clinicians, to take care of people as quickly and as soon as possible. And I think we're very challenged in that regard at this point in time. And I believe Oliver Wyman will make the mention of that as well, that preparation to be able to be ready for global budgeting requires more physician complement than we currently have. Again, I'm supportive of a study being conducted. Tennessee has taken that step where they, I believe, grant temporary licensure so that quality is still evaluated over a 2-year period as well. And I'm in favor of a study being conducted so that Vermont can hopefully find innovative ways to enhance access to clinical care while maintaining the very high quality of clinical care that is already being provided in the state. So that's my support for Act 263. I applaud Senator Harrison for thinking out of the box and trying to help with the challenges of access to care here in Vermont.
Thank you. Do we have, if we could get your comments in writing?
I will get them to you. Yes, indeed. Thank you.
That'd be terrific. Thank you.
Thank you.
And then we have, is it Virginie? Virginie? Is she still there? She's okay.
Yes, I am.
Oh, good. All right. So we'll get you up on the screen and then, thank you for being here. And we welcome your testimony on the bill.
Thank you so much. My camera is not on, so Honorable Chair, Vice Chair, and member of this Senate of Health and Welfare Committee, thank you so much for having me here today. I was asked to comment on the reason we need to support S263, an act relating to expanding Vermont's healthcare workforce through graduate of international medical school. This act will be a lifesaver for many trained practitioners relocating to the United States, specifically in Vermont, for non-American patients and the larger population. This act will contribute to the state's overall wellness. For the record, my name is Virginie Diambo. I am originally from Brazzaville, Congo. In 2005, due to the war in the Congo, I relocated to the United States in Vermont with my husband and our 4 daughters. I am a trained radiologist physician, but I never could transfer my credentials in the United States. Therefore, I never could work as a physician. I am currently employed at the
Whoops,
yeah.
you're here.
Oh, okay. I am currently employed, sorry, with the Champlain Valley Office of Economic Opportunity, also known as CVOU. CVOU is a member of the Vermont Community Action Partnership, which is comprised of 5 community action agencies that work together on anti-poverty efforts. Serving as the director of the Office of Racial Equity and Community Inclusion is what allows me to advocate for diversity, equity, inclusion, and belonging, and fair access to resources for all Vermont community members, for all Vermont community members. Indeed, I was unseen and transparent for 15 years in this country. I fought a different kind of war than the one with guns and bullets that made me flee the Congo. It was to put food on the table for my family. Although a trained physician, I had no choice but to work an entry-level job in a medical facility. I learned the English language on the go. I had to meet my family's needs while ensuring my income stayed low enough for my husband to benefit from Medicaid coverage. My husband was clinically ill. He never worked in the United States, and I could not afford to pay or contribute to the cost of his treatment. He passed away a few years ago. My husband and I wanted the best possible education for our daughters. We made them to understand that as refugees, women and Black African, they had to work 3 to 4 times harder than white peers to give themselves a chance to be seen, heard, and exist. They are now adults. They each earn a master's degree in science, and one is entering her third year as a medical student. However, my family and I went through all possible negative feelings, disappointment, frustration, anger, episode of depression. We often had to work 18 hours per day and sacrifice family life to reach our goals. I recently had to change gears, enroll in college degree courses to become a social justice leader. And even though I work in a leadership position right now, I still miss working as a physician. I want to say to this committee, what I want to say to this committee is that life could have been different and bright for my family and me. And if there were accommodations, system in place, or pipeline set that could have helped me get back into my field of expertise. That there was none, and there are still not any for graduates of international medical schools. Vermont is a refugee state with an estimated 8,000 refugees who resettled in Vermont for the past 14 years. Among these individuals resettling in Vermont, several are graduates of international medical school who have no other choice than to push a janitorial tray every day of their life to try to meet the need of their families when intensive training, recertification, or enrollment in peer mentoring program would have equipped folks to acquire the American standard of care and therefore join the medical workforce. Is it necessary to say that the fundamentals of medicine are the same and that the human body functions the same regardless of skin color? Vermont providing an opportunity for graduates of international medical school to be recertified will be of tremendous help, and as it will change people's lives. Here is how. Graduates of international medical school will be getting back in their medical field of expertise, which is mentally essential considering the number of years folks spend in school. They will help and treat their peer community members in their languages, which will avoid the use of interpreters who sometimes do not convey the message faithfully from the provider to the patient and vice versa. Therefore, having a provider that speaks the client's language can also help avoid paying for interpretation services. Another fact in favor of working with a provider that speaks the same language as a client is when working with a patient who has mental health disorders, for instance. Some cultural consideration may come into play when the person is developing these issues, and a provider with the same cultural background as a client could better address the patient's needs. For instance, walking the dog, a recommendation that I hear often does not apply for many of our community members. Graduates of international medical school will also bring in their global medicine expertise, which will enhance the whole medical team's expertise and prevent the hospitals from being sued for malpractice due to the team's and familiarity with global medicine. And this malpractice and the suing erode trust in the health systems to the community members. Folks will have more income while working fewer hours. They will allow for more family time and children supervision. Overall, the level of stress, anxiety will be reduced or disappear to people, and the risk of developing mental health disorders of substance misuse behavior due to frustration and anger and the uncertainty of life will also disappear. So what I think we have to do is to support S263. And one of the ways to support this act would be to work with the USCRI any refugee resettling to the United States must undergo a thorough interview before traveling. Therefore, the USCRI holds the files of all the individuals relocating to the United States. Therefore, identifying graduates of international medical schools and assess people's interest in enrolling in medical recertification programs could be considered. Making grants or loan without interest available to the non-English speaker graduates of international medical school to enroll in intensive and medically oriented English classes will help. The mode and term of the reimbursement of the loan could be discussed. It could be similar to the one set by the Immigration Office regarding the reimbursement of the ticket the refugee repay to the US for their trip. We know that every refugee resettling to the US has to pay for their trip ticket back to the United States. Another thing also would be to review the cost of the medical board exam for a discount to accommodate people. So in conclusion, I think that creating an act related to expanding Vermont's healthcare workforce through graduates of international medical school for those who want it would be beneficial to everyone. It will be a win-win for the medical practitioner, the patient, the medical system, as many refugees are relocated in the United States and in Vermont specifically. And I also think that this act will help with the state well-being overall. Thank you very much.
Thank you very much. We appreciate your time and effort and all the work that you're doing and the background that you've shared with us. This is very helpful. If you could please send your testimony in to Kiki, and so we'll have it on our webpage for reference. That would be very helpful.
I will do. Thank you so much.
All right, thank you very much. So we're going to move along from S263 and head out to S114. We're really trying to get an understanding of what the thinking is on each of these bills, and then whether we can do anything in the final week before crossover. We'll have to have a consideration of that. So we're going to move on to, we've been through the bill once. Is Charles McLean? Yes, there he is. Okay, welcome.
Thank you.
Yeah. So, well, our time is somewhat limited. We have until about 11:35 or a little more than that, 11:40. So anything, so you can judge
Yeah,
your
I have a presentation that will take me 13 to 15 minutes to go through, and I've submitted it already to Kiki.
Okay, I think we can handle that. And then we have Catherine McLean, not related, from Johns Hopkins also.
Great.
So if you can get it to 10 minutes, that would be really good.
Okay, I will talk very quickly. Somebody's going to have to allow me to screen share.
All right.
So thank you, everyone, and happy Leap Day. I'm going to be speaking today about Vermont stakeholder views regarding psychedelics, and I'm not going to be speaking really about the bill specifically, advocating for or against. You can see my credentials there, and this work was done with Liz Cody from the Office of Primary Care, and then students from Larner College of Medicine, class of 2026. No conflicts of interest to disclose. The outline of what I'm going to cover is a little background, rationale for the studies that we had done, and we're going to talk about qualitative interviews project and then a full survey at primary care. This timeline of psychedelics, quote, mind manifesting compounds, shows that they've been used for millennia. In the 40s, there was some active research that kind of decreased with overuse potentially, or popular use for recreational purposes in the counterculture movement. And then in the 70s, the move to Schedule I status, which really restricted scientific study. And then in the last 20 years, we've really seen an increased interest, particularly in academia and industry. And now in the 2020s, we're seeing states and cities really enacting laws to enable access to psychedelics. So what are we talking about when we talk psychedelics? The main sort of categories of compounds, if you will, are those that have sort of a dissociative mechanism, like ketamine and MDMA, and then those that have a hallucinogenic mechanism. So this is relatively simplified. That includes psilocybin, LSD, and ayahuasca. And in this table, we tried to show sort of in our lit review where the evidence is the strongest. So ketamine is actually FDA approved for refractory depression, and it's in use in Vermont. MDMA as an accumulating body of evidence for PTSD, and it's anticipated the FDA will approve it for that indication in the coming year. And then the primary areas of focus for psilocybin, LSD, and ayahuasca are shown there. And anxiety conditions includes end-of-life existential kinds of anxiety. That's a particular interest of one of our faculty members at the Larner College of Medicine. So our rationale in wanting to collect stakeholder perspectives was that if we can clarify these for Vermont, it might help with policymaking, research prioritization, and then educational programming, which is what we do a lot of in my office of primary care. So our broad goal then was to assess knowledge, attitudes, and beliefs of various stakeholders. So in the first study, we did a lit review to develop an interview guide. We elicited input from 16 different stakeholders, including primary care folks, psychiatry, palliative care, psychologists and counselors, nursing, legislators, law enforcement, advocates in favor of psychedelic access, and then also people who are investing in the industry and trying to figure out how it could be a profitable endeavor for someone. And then we analyzed the results to kind of summarize what we heard. And we categorize these into three big bins. One is around sort of what's the current environment and people's understanding of the current environment. What are some of the implementation considerations that might be important for people to pay attention to? And then concerns. So the summary, this is the summary slide of all of those things. I'm going to go through each of these bins separately, but this is kind of like the big picture. So in terms of the current environment, what we heard from people is that, yes, there's accumulating research. Psychiatry is now recognizing the promise that psychedelics seem to offer us more than a half a century ago. And at the same time, we're seeing changing policies. So we know that jurisdictions around the world and around the US have been making access to psychedelics more liberalized. And then we also heard that, there's this compelling need, maybe based on the growing mental health crisis, to find solutions. And if psychedelic therapies can offer help with that, it's contributing to this environment of interest. Under implementation, the three broad things we heard about was this decision for policymakers in terms of how to, if there's an interest in making access more available, whether this should fit into a medical model. So this is for treatment of specific conditions in a medical kind of environment, or if this should be more a personal use model for spiritual exploration or something more broad. So that's a big divergence that I think we'll see in many other jurisdictions. The concept of set and setting or mindset and setting are critical. This is discussed everywhere in the literature, and I think people here understand it. This isn't just about taking a particular medicine or compound. It's really about everything that wraps around that, both before and after. And so setting those things up is really critical. And what goes along with that is, so what are the qualifications or thresholds of education that might be required in terms of setting up an approach to access? So, the quote we have here is, who gets to decide what a good guide is? Under concerns, safety concerns, always an important thing to think about when new compounds are being used, or if increased access is made available. And certainly that first quote there, I want the provider to prove to me that the approach is safe. But then there's also this quote here about the direct toxic effects of these compounds are probably less concerning than a lot of things that are currently available, including tobacco, alcohol, opioids, benzodiazepines. The concept of overzealousness came up, so that's I liken this to sort of the approach to cannabis, where there's this huge enthusiasm that cannabis would be very effective for a lot of things, and that probably has not really panned out. And I think the access issues around cannabis got out way ahead of the evidence that was there. So we do have this opportunity now, I think, in the US and in the world to really establish good research on where these compounds may be most useful. And then finally, we heard about accessibility and equity. So this first quote, I think we shouldn't legalize any of these things until we can offer it to people who can't pay. So there's this notion of, is there a developing industry that's going to cater to people who can afford to access psychedelics? So discussion points we kind of thought about here were that therapeutic potential is still not super clear, and there's a ways to go on that. There's still some barriers to getting research done, but I'm optimistic about the direction that's going. If we do get over enthusiastic and out in front of the research, that could lead to a backlash similar to what we had seen in the 60s. And then this opportunity to really explore the therapeutic potential for specific mental health conditions. I'll switch gears now then and talk about our primary care survey. And here, similar goal of trying to assess knowledge, attitudes, and beliefs, but more focused on primary care population in the state. So we developed specific survey instrument based on the content of our stakeholder interviews. We distributed, there's about 1,000 PCPs in Vermont. We have a good email list for about 770 of them. You can see the categories of medical or nursing or PA degree here. Our response rate was 17%. Here are the demographics, which are pretty representative of PCPs in Vermont. And we had good representation from the different business models that people practice in. So on the knowledge front, we asked the PCPs to identify the regulatory status of psychedelics. So for example, ketamine is FDA approved. And MDMA is probably next in line to be FDA approved. And you can see that the proportion of the respondents who got the regulatory status right varied between 40 and almost 70%. So not, there's a knowledge gap there, which is not surprising. In terms of their beliefs, this is sort of like what I think of as the cautious optimism slide, where, in terms of responding to this statement of, I believe that psychedelics have high therapeutic potential, more than half agree or strongly agree, 40% are neutral, and only 4% disagree with that statement. So there's optimism out there. In terms of specific concerns, our respondents were moderately to very concerned about use among youth. And I think that also kind of reflects the way we think about alcohol and cannabis. Driving safety, I think, as in Vermont, that has been a big concern regarding cannabis. And so it's reflected here. But then again, going back to this issue of, are these compounds, do they have a primary deleterious effect on someone's health? Only 17% were concerned or very concerned about that. In terms of education and research gaps, so the 77% of the PCPs, the primary care folks, were interested in further education, which is good to hear. And then 64% agree or strongly agree that research on risks and benefits should be a high priority. So discussion points here, I think we have a knowledge gap, but people are interested in learning more. So, my office is thinking about either academic detailing or ECHO program focused on this. I think there is this guarded optimism, and then obviously concerns regarding safety. A couple of limitations about both these projects. I think like any work of this type, participants may not be representative of all important stakeholders or all PCPs. We had a relatively low response rate in the survey, but I think the folks who responded were representative demographically of the entire population. And then the research evidence is being rapidly updated so that these results, may get outdated and need to be updated to stay in sync with what's actually going on. I've provided an accompanying document that is some selected references. It's got about 20 or 25 references on it for your info. And with that, I'll be happy to take any questions.
Thank you. It's a lot of work. I know you said you were going to be doing a project with folks, but this is pretty comprehensive and really appreciate it.
Yeah,
So,
we have been able to present this at a national meeting out in San Francisco, and we have another presentation that we're giving in Boston at another national primary care meeting.
thank you. Questions? Okay, well, we may come back to you going forward. So there are two sections of the bill. I mean, one section is decriminalization that is not really our jurisdiction, but something we would want to consider based on efficacy of use and how well it's been researched. So
yeah, and I had also provided a recommendation to the committee that that we do have some real experts on psychedelics here at UVM, one in palliative care, one in pain, who might be, who I know one in particular was interested in testifying, but he's traveling today. So he'd be happy to testify or provide written info or have discussion.
thank you. Okay. So we also have with us Dr. Catherine McLean from a former Johns Hopkins researcher, and Dr. McLean, a different Dr. McLean, not related from what I understand. So
Yeah, probably related at some point in time, but
so yeah,
not that we know of.
So is Dr. McLean up there? Okay.
Hello, I'm unable to start my video. If someone could start it for me, that would be fantastic. There we go. Hi, everyone. I'm tuning in from Southern Vermont in Whitingham, where I'm actually a school teacher right now. I've worn many hats in my life, and I've been living and breathing the reality of the impact of these compounds in people's lives since about 2009, when I started work at Johns Hopkins School of Medicine under Roland Griffiths, who is a real giant in the field. He passed away last year of colon cancer and has done a huge amount of advocacy and research to restart this very important work. And so it's my honor to work with him in the early days. Thank you so much for considering this. I know it's, even though there's a lot more interest, research, grants, investments, and changes in the law, it's still a very controversial topic. I remember when I started this research in 2009, I couldn't even talk about it with most of my friends and family. And the Department of Psychiatry at Johns Hopkins was very opposed to the research. So it's amazing actually to see the change that has happened in such a short period of time. And what I can say is that the people who are doing this research are passionate, but also very concerned about safety and education. When I began my research at Hopkins, I was a postdoctoral research fellow, and then I joined faculty. So for a very brief period of time, I was one of the only women in the world who was a faculty member exclusively studying psychedelic compounds. Sadly, my sister died of breast cancer shortly into my tenure at Hopkins, which prompted another period of my life. But that's basically the only reason I'm a former researcher and not a current one. At the time, we were working with cancer patients who had anxiety and depression, people interested in quitting tobacco smoking, and actually a lot of healthy people. So we worked with young people, people in middle age, retired folks. We worked with meditators, people who had never taken a substance in their life and were 80 years old and were coming to us to be part of science. I personally have guided over 100 sessions with medium and high dose psilocybin in the synthetic form. And I've worked with hundreds, if not thousands of people all over the world, teaching about how to increase safety and education around what happens before and after a psychedelic experience. And what I can say is certainly what happens before and after is at least as important, if not more important, than what happens during. And so my perspective kind of comes from two hands. The first hand is from the medical context, which is where I got my training. I can say 90% of the time, that context is the safest and most effective way for someone to have this kind of experience. It's not risk-proof. It's not without its consequences, but in most of the ways that people are concerned about safety, I would say we addressed that to the highest degree we could at Hopkins. Now, people are using psilocybin right now. People are growing their own mushrooms. People of all ages are using this medicine all over the country. There are risks and benefits to that. But what I can say from meeting these people over the course of my career is that almost all of them are using it for health reasons and for well-being and spiritual betterment, not for recreation or entertainment. Of course, that happens, but I would say the large majority are interested in health and well-being. So the fact that this is being considered by this committee is very appropriate. I've met people who, sorry, my phone is ringing. Like I said, I'm a school teacher. I've met people who were suicidal because of chronic headaches that would not remit. I've met people who had tried every other depression treatment, every kind of therapy, and were at their last, the end of their rope. I've met people who were plagued by distress at the end of their life. And in all of these cases, in a way that we still don't know scientifically how it happens, psilocybin seems to be powerfully transformative for these kind of situations where someone has tried everything and is still very deeply suffering. And when people are using a medicine on their own for that kind of suffering, it doesn't matter if it's legal or illegal. They're going to make this decision anyway. So what I would say is that if we can increase access to the medical context, for sure, but also the decriminalization of psilocybin, I think, is actually imperative, because right now people are making this choice. And when something is criminalized, they're less likely to talk to their doctor about it. They're less likely to seek medical assistance if there's an emergency, and they're less likely to know the full scope of what they're doing. And so there's a lot of research that as a mother of 2 young children and a full-time school teacher, I didn't have time to prepare a full thesis on this, but there's a lot of research showing that a model of decriminalization actually increases safety around drug use for pretty much every drug out there. It's not perfect. We're never going to get to a perfect state of safety, but it helps people feel less shame, fear, and embarrassment about talking to their doctor, getting education, maybe even talking to their family about it. I certainly know people at the end of their life who are nervous to bring this up with their family. And so I would love to see a compassionate approach to this that sees the reality, which we're facing, which is people hear the news, they read the research papers as reported by the press, and they take matters into their own hands because we're in a mental health crisis and we're in a crisis of pain as well. So I'm strongly in support of both aspects of this bill. I would love to see more research. I would love to see greater dive into what the therapeutic potential is of psilocybin. And at the same time, I think that the reality is that a lot of people in Vermont could benefit from this. Like I said, it may not be perfect if we don't have the medical context, but I think it's a great start to remove criminal penalties. I work with high school children. As we all know, they do what they want. And so I would love to be able to educate teenagers about this kind of medicine so that when they are adults, they can make really good choices. It might actually reduce alcohol use. It might reduce other dangerous drug use because we've seen in the research that psilocybin actually does interrupt addiction. The final thing that I'll say is on a personal note. So I'm a mother of 2 young children. When my sister died in 2013, it was like falling into an abyss. I sought therapy, I sought treatment from medical doctors, but ultimately I sought treatment from the medicine that I had seen help so many of the folks that I worked with at Hopkins. And without those experiences with psilocybin, I'm not sure that I would be alive today. And I'm not sure what kind of mom I would be, what kind of functional teacher I would be. And so it's a very personal topic for me. And I know that I have always had a fear of what would happen if something criminal came out of my own desire to ease my suffering. It's a concern I live with every day. And I know that other parents and caregivers think about this. You know, what would happen if I have to treat my headaches, but someone found out that I was using an illegal drug? And I would love to remove that fear and concern for people who are just trying to feel better. So I think the final thing that I would say about the medical context, I've had visions of what an amazing psychedelic research and treatment center could look like. It's possible that we could create that here in Vermont. It would take a lot of money. It would certainly take a lot of funding. And right now, the barrier to access for most medicine is expense, it's cost. In Colorado and Oregon, we've seen that psilocybin service centers that are being created are inaccessible to most of the population. Sessions are costing $5,000, $10,000, $15,000, $20,000 a pop. And even with insurance, we know insurance is inaccessible to a lot of folks. So I would love to really think about that expense side before we prematurely decide that possibly the medical context is always the best choice. Final point, I know we only have 2 minutes left, is that I've been working a lot with people who actually have been harmed by psychedelic practitioners. And my enthusiasm is only slightly dimmed by these examples. But what I would say is some of these women who have been harmed either sexually or emotionally or financially by unscrupulous practitioners, those folks had licenses. They were medical doctors. They were therapists. They had review boards. They should have been following the ethics of their profession, but they weren't. And the women were afraid to come forward because of the criminal nature of the drugs that were used. And so again, I would love to see those penalties, that part of the bill, strongly supported, because I think it will actually reduce the risks, even within the medical model, of folks being harmed by bad actors. And I think that's it. I really appreciate this opportunity. And yeah, I'm so honored.
Thank you. No, but thank you very much. And it would be helpful to have your testimony in writing if you can get it to Kiki. It is very compelling, and your personal story especially. So we greatly appreciate your sharing that with us. We know it's not always an easy thing to do. So thank you for that. And it does exemplify some of the value that we're hearing about for the use of psilocybin and the decriminalization in particular. So thank you very much.
Thank you. And thank you to Dr. McLean for your excellent presentation. I'm sure we are related somewhere back in the ancestry.
My brother is a genealogist, so he will figure it out.
This is great. So, yeah, maybe there's some link in there, right? That's why you're both doing what you're doing, who knows? So, we'll move on to Kurt White. Kurt, you're here. Why don't you introduce yourself and tell us where you're from? And we just heard that there might be an opportunity for a center in the state of Vermont. And I immediately thought of Brattleboro, but there you are. So,
I would love to connect with Dr. McLean, both of you, Dr. McLean, so about that, especially right there in Whitingham. That's wonderful. So fine. But great. I'm Kurt White. I'm a social worker by trade and training. I work at the Brattleboro Retreat, where I've been for almost 20 years. I've been in the mental health field for over 20 years. I've been in different roles at the retreat. I've been overseeing the outpatient programs until recently, and I'm the vice president of community partnerships, and which involves a component of new initiatives and program development. And I am here in support of S114, both the aspects of it, actually, the legalization and the development of the commission aspect of it. And I'm going to share my screen briefly. I will be brief. I know you're on a timeline. Oops, if I can get the screen sharing enabled. There we are. Very good. I just want to speak to the transformative potential of these psychedelic psychotherapies, and to the sort of quality of the research that has gone into to this. Much of it happening at Hopkins. I'm so glad we could hear about it directly. I think these substances as a whole, but perhaps psilocybin in particular, have a potential to be one of the greatest transformational leaps forward in the mental health field in quite a while. And I say that as a natural skeptic, someone that was not really in favor of this sort of marijuana bandwagon, and have seen. And who comes to this sort of slowly and out of a long immersion in the emerging research. But the research related to psilocybin, as you've heard, has really been tremendous and sort of cross-cutting across people's diagnostic categories. We have potentials for anxiety, for depression, for end-of-life sorts of issues, potentially for obsessive-compulsive disorder. Some amazing studies that have been happened related even to things like smoking cessation, where people are getting results leaps and bounds better with just a few treatments with psilocybin and therapy. Maybe double or triple the sorts of results that we get with the best therapies that we have available today, sustained over long periods of time. I think in the mental health field, so many of the conditions are so hard to approach and hard to treat that we've sort of expected a kind of incremental gains to things. We're actually, like in the rest of medicine, we actually sometimes have great leaps forward. We have, immunotherapy treatments in the cancer realm for some individuals, and monoclonal antibodies. And I think this is our sort of thing like that in the mental health field. And I think that Vermont has a real potential to be innovative here, to be a leader in this field, and to make a real difference from some people out there who really need help. I also think that, sort of much like testimony you've already received, prohibition does not prevent use. This has been well demonstrated. People are using it. They're just more hesitant to talk about it, to seek help, to ask professionals questions about how to do things safely, to know when they should be worried about conditions that might be contraindicated. And I also would just sort of point out that these are substances that grow naturally in horse manure. So it's a little bit weird for psilocybin in particular to be sort of criminally regulated, in my view, since it really is sort of something out there in the world that people can find. I also think that the research nationally and internationally on the risks has been demonstrated to be really very low, not zero, but very low compared especially to other substances that we might compare it to, and that the risk of addiction or compulsive use is also very low. In the very rare instances when it occurs, is probably more psychologically than physiologically driven, doesn't seem to affect the dopamine pathways in the brain in the same way. Those are the sort of parts of things that get hijacked with the substances of abuse. So I'm really hoping that we can move on S114. I would actually request if the Brattleboro retreat could be added to the language to be a part of that therapeutic advisory working group. We very much want to be a part of this transformational event that I think is about to happen in the field of mental health. And we urge the committee and legislature to act quickly on this issue, and to sort of reiterate that sort of both sort of delays and prohibition, I think, actually are more likely to cause harm, because there will not be appropriate guidance, oversight, or an environment that's conducive to people sharing their honest experiences about substances, and are not necessarily effective in decreasing use anyhow. So I can take some questions about that if anyone wants.
Thank you. This has been really terrific testimony on the bill. We greatly appreciate it. It kind of makes us think about the next steps, the critical next steps. As I said before, our committee can recommend decriminalization. It would have to go to judiciary, another step. I'm wondering if there's a way that we can consolidate the working group to ensure that that next step takes place somewhere along the line. Because our job on this bill, the most time we have is the week after crossover, a few days. But it does make sense to look at this therapeutically and to make it available where it's efficacious. And that's what we're hearing. And that it has been so useful, and including to Dr. Catherine McLean. And so to continue that access for patients sounds very important. So, and so we will, as a committee, do you have any questions for folks or comments? I'm happy for us to do that right now. We have just a couple minutes. Senator Gulick, it's your bill that you introduced. Did you want to make a comment?
I more have a question about how we could, is it possible to be able to move the bill with the decrim piece in and send it to judiciary, or is the time?
That's a question that we can ask of judiciary, and I'll look to Michelle maybe to help us out with that a little bit. I'll talk with Senator Sears. I don't know. It would be important for them to hear the testimony that we've heard, if that's possible. There are costs, there may be costs associated, I'm not sure. But
with decriminalization?
probably not, right?
No.
So we could make a recommendation.
Right. You could also put it as part of the working group's charge.
Yeah.
Is, to look at that particular issue, and they could explore, like Dr. McLean had talked about, in terms of because of certain barriers, not making it accessible to everyone, but people using it on their own, is there an overall benefit for it to decrim? And they could, when they come back with their recommendations, they could make recommendations to you on that.
That's a good idea. I think on the $10,000 to $15,000 access point is unbelievable.
Yeah.
So so that probably is the.
And I can work on language for that.
That would be helpful.
I can do, because I know your time's tight. But I could do a revision of, amendment for you. I could add the Brattleboro retreat to the working group if you'd like, or.
And other, so we can talk about that. I think the folks who are here are important to that work, however it happens.
Can we ask them that question? Would that be a workable solution for you all, to put language around decriminalization within the working group?
I mean, I would think it would be very important and necessary. I don't know how all of this works. There's certainly a sense of urgency, but I don't think another year is going to make a big difference. So if this is the smarter way to do it, to ensure that it's considered fully, and then, but I also think if there's still the possibility of the decriminalization part being considered, it would be amazing. You know how all these things work and how fast it can work. So that's my 2 cents.
May not work that fast, but we can certainly have that conversation with our peers, sort it out. But the suggestion that you've made, Michelle, I think is probably what I think is possible, so, or probable. Any other questions or comments? No? Thank you all. We have, and so Michelle, why don't you just come up for a minute? We can talk about how we might, improve that, your thoughts on how we might improve that language based on what we've been hearing and talking about. Well, we have you, in the answer, put you, sure, not that you're not already overworked.
Do you want to take a look at the language
Sure,
or,
let's do that.
is everybody has access? to
Yeah,
the
and we've got
document?
Katie coming in about 5 minutes.
Sure.
So I'm thinking that.
Sure, so I will skip over the findings and the decrim section. We'll go directly to, if you look at the bills introduced, section 3 on the psychedelic therapy advisory working group. And so I would say, just with limited time here, take a look at your membership. The number of folks who were there. So it is a legislative committee, so there would be folks who would be appointed from the House and the Senate on that committee. You have a member of the Psychedelic Society of Vermont, someone from Johns Hopkins, somebody from OPR, and a member appointed by Decriminalize Nature. So, you might just want to be thinking about how you want to, who you would want to be on that committee. I would recommend that you don't make it too large, because then it sometimes is difficult to come to some consensus and have a really workable product for the legislature to act on at the next time.
How do we get, the medical school, UVM medical school engaged in it? Because they're not, I don't see them there.
You can add them, you can take somebody off, you can substitute.
Well, I was thinking, do we need two reps and 2 senators?
I don't even we need legislators on this at all.
I'm ready to agree with that. So
No, I
do
don't-
we need legislators on this?
And then it doesn't have to be staffed by legislative council and everything. I mean, can't we just make it a working group that we ask the medical school to
Well, we
take the
could
lead on, or
ask-
some other entity to
Yeah.
take the lead on?
And I see that OPR is there. Yeah, so let's take, does anyone want legislators on this?
I'm fine with that.
Okay, gone. So that gives us the opportunity to add the University of Vermont Medical School.
Mhm.
That's good.
The one thing we have to make sure that if we take off legislators, we can't have it staffed by the legislature.
No,
That's-
we don't want leg council, who's staffing it now?
It would be me. It would be me under this.
Yeah, so-
But if there's no legislators.
What is a good suggestion for that? Because it seems to me that's a huge burden.
Right, so I think, why don't you tell me about thinking about the people who should be on here, and you're really kind of wanting people who are really steeped in the like
Yeah,
our witnesses
That's
here
what
today.
I'm wondering about OPR.
Well, okay, that's the thing, is that you could have, just put something in there so that they're in consultation with
Right.
OPR or something, because the licensing is just part of the piece, from hearing from the witnesses. It's not really just about how do you create something like what Oregon did, or whatever. So you're looking for whatever would work best for Vermont.
I'm thinking of on the decriminalization, if we're gonna add that language in there, who can speak to that? Having a one person.
That's a good question.
I think it depends on the approach that you want to take.
Therapeutic.
Because if you're looking at kind of having like health practitioners and looking at it from that aspect,
Sorry.
and looking to get their view on potential benefits or harms caused by decriminalization. I mean, you could always, ask them to take, certain testimony from certain folks, but I think, you'll have, I'm sure, very divergent opinions, perhaps from like the medical witnesses here versus law enforcement. I mean, I don't know, I can't speak for them, but, so I think you just want to make sure that you're not creating a committee that,
It's gonna do what Act 27 did. Committee, that was a,
I don't know what that is, but
No,
I think it was functional.
you don't know, it's okay. Okay,
Um,
can we ask for you to do this? We have Katie.
I'll
here.
play around a little bit. and
Play
I'll-
with it a little.
Why don't you
bit.
guys send me, yeah,
Yeah.
you can work with the senator on kind of,
Yes, why
reconfiguring
don't
this
we work
working
with
group.
Senator Gulick on this and the rest of us can feed our recommendations to one or other of you.
So is the intent not to have the contra view on the working group or?
And not to have what?
Contra.
Oh,
I understand the comment about creates friction and such.
well, it depends on what the,
Policy.
it depends on what the language is regarding decriminalization. So, it could be that decriminalization is going to get in the way of therapeutic use. So the value, what we're looking for is the value of therapeutic use, I think.
And that's what I'm like trying,
Yeah,
it seems as though you're looking for healthcare providers to weigh in on these values. And then there's of course the other piece to that.
Mhm.
And you can either direct them to take this way, but it may not be like for health providers to be
Weighing in on
weighing
everything.
that piece.
Right.
You know, it depends on what your purposes are with the working group in terms of looking at it from the health perspective.
So this is what I'm gonna suggest. I think if we want to look at S-189 briefly. I'm gonna suggest that you feed your thoughts to Senator Gulick and Michelle Childs. Look back there. If there's an interest in coming back with a recommendation on decriminalization, then you need to have something, but.
And if that's
Depends
too
on how it's
complicated,
worded.
you can take, that piece out and deal with it.
Yeah, what about someone from the Department of Health? Would that make
That's up
sense?
to you, that's a good idea.
Okay, maybe we'll talk.
I'm gonna move on to Kate.
Okay.
Thank you. And we will, I think it's like we'll come back to this after the process, after, what is it, town meeting week. Katie, here you are.
Here I am.
I'm hoping that the things that we're doing this week will lighten our load the next week back, not lighten it, but make it feel. Thank you.
Good morning.
Few more minutes.
Yeah. So we don't have 89 up there.
I should pull it up for you.
Okay.
I'm in process here. There we go. Meeting with the Legislative Council. I pulled up the most recent draft of S-189, which is draft 3.1. It has not changed since we last seen it. So the highlighting is the last highlighting we looked at. Just to refresh your memory, this is the mental health response service guidelines. And you've added a section on social service provider safety. This is the meeting that will be convened and the group can come back and present findings.
Can we look at the group?
The makeup of the group.
Yeah. Okay. What
This
about
is a voluntary list, so it's a.
Yeah, the disability service provider, I had an email from the ombudsman.
The what?
I sent you an email that I had received from someone who wanted to be a part of this group.
I'm sorry, I don't remember.
Well, okay, it was last night, it's last minute, so my suggestion is to leave it, don't need to go there. It was someone from the disabilities community, it was Lindsay Owen of Disability Rights Vermont. Thank you, Kiki.
Are we on draft 3.1 section? We are.
Yeah.
Can you bring that up then?
Yes, but then I can't look for the email, that she's asked me to, could we print you a copy and I can?
Yeah,
No, I thought you were focusing on something. Right.
I'm looking for the email that I missed.
It was from Lindsay Owens. She had, when she testified earlier on S92, she also commented on this bill, and I think we failed to keep that in mind. So I failed to keep it in mind. So we can add someone, add the director from Disability Rights Vermont on into the working group at the committee's discretion.
But they wouldn't be prohibited from participating because it says, well, let's see what it says.
There's,
Mental health and healthcare providers, community action programs,
we could just put,
disability service providers. This is like you said Disability Rights Vermont.
Yeah.
So disability service providers and advocates.
yeah,
Okay, why don't I make that change?
is that okay with the committee?
Wait, what does it just say? It just says disability service providers.
Providers, and so I would add and advocates.
Oh. I mean, it's just a May list. I think it's actually not a big deal, but.
These are mental health protocols, guidelines intended for EMS services, so how come they're not?
This is the different thing. This is about the social worker.
This is the social work.
Remember, we got the
Piece.
testimony this is not about the guidelines. This is about.
Sandal.
Social work, yeah, we've
It's in the
added
same bill, but
an
this is
amendment, which would direct a meeting with this group around social work, violence protection, and so the full people involved. That was the testimony, that was the thing that we added. And Liz is here. So this would add Disability Rights Vermont, we're advocates.
No, what I just did is I added, the last, item on the list. Where is it? It's disability service providers, and I have turned that into disability service providers and advocates.
Okay, it's okay. Is that okay with Liz? I see you shaking your head.
Nothing is
Okay.
draft 4.1. It's draft 4.1 now.
Which is it? Do we have that?
Nope, I'm writing it right now, sorry.
Sure.
I know, no, what else to be?
No,
What's the net impact of this working group or group?
Liz, what's the net impact of this working group?
For the record, my name is Liz Mills, Zach Harper Consulting on behalf of the Vermont chapter of the NASW. So net impact is to hopefully provide legislative body recommendations next session so that we all can work together on social service worker safety. So right now it is fairly broad, and that's why the purpose of the working group is to allow this group and the advocates the ability to look at this issue.
Coming from the field. And there certainly has been violence against social workers.
I get that.
Yeah. Just it gives
I've
them,
lost context and how the original problems migrated into this analysis.
it didn't migrate. It was a request brought to us from Liz. It is not, it's related but unrelated.
There's the top of the lead-in language, if that's helpful.
Is there like a purpose statement? Something like what the goal is?
No, it's drafted. I mean, there's a final, their final
Yeah.
responsibility says that they would present findings and recommendations.
Findings and recommendations for what?
What their conversation was about.
Can you go up to sign? It's in two. Oh, wait, go back, go down. Go down to number 2, scroll down. And 2 is
In advance of the meeting or meetings described in the subsection of
studies related to provider service.
I don't
So-
think that was an appropriate comment. That's really unfair. These are people
I
who
retract
died in
that.
the line of service.
I get that, I just.
This is a request from the social service provider community. so that they can get together and that there's a charge given to them so that they can bring recommendations back to us and that there is a guarantee that they will be convened and that they will bring back a presentation to our committees. That's all it is. And that happens a lot. It's a working group for which our Ledge Council and our Joint Fiscal Office will not be responsible. The responsibility will lie on the social workers themselves to get together. But it's something that we would look for. We did this a few years ago when we had the Child Protection Advocacy working group, but which did include legislators. It did come back with some very strong recommendations about limiting violence against fighters and others. So that's it. That's the bill. We've looked at it several times.
I'll make a motion to vote positively on S-189. Draft 3.1, 4.1.
4.1.
Second.
Okay, discussion. Okay, clerk.
Senator Hewlett, yes. Senator Hardy. Yes. Senator Williams,
Yes.
Vice Chair Weeks.
Yes.
And Chair Lyons.
Yes,
Okay, voted out 5-0-0.
I'm glad it presented. So that's good. Good work. We can go off live. This bit. We didn't have anything else to run today.